Good morning, everyone. First, once again, thank you so much for inviting me back, both to the conference and for a second day. Really excited to be here and was having a lot of fun listening to the discussions, some of the questions that came up, and the general direction you're going in. And you can see kind of all the pieces starting to come together. So it's really exciting to sit back there and kind of silently observe and watch as you guys think through how you want to position yourselves to make an idea like this happen in Canada. So for today's presentation, we're kind of going back and forth on what would be most useful to present. Is it kind of like go deep into data standards, and really focus hard on how IT departments should store them, what's security measures, things like that. Looks like you have some speakers coming in later today on that topic. So we said, okay, what is the kind of pieces that you really have to understand about value-based healthcare and data that, from at least as a patient advocacy perspective, would be integral to your understanding of the concept of value-based healthcare. And this is often glossed over a bit, where people say we should measure outcomes. And sometimes they'll say, well, an outcome could be something like pain. But you don't really get much more than that. It sounds somewhat subjective. It sounds something like, well, don't we measure pain already? Doctors usually ask me, how much do I hurt, and how much pain am I experiencing? And so what are these outcomes, and how does that actually work? What would a standard set of outcomes look like if you were to adopt one or create one? How would you want to measure it? What other things would you want to do there? So what I really want to walk into is, we keep talking about the value equation as kind of outcomes over cost. Let's really talk kind of end to end, one full use case of what those outcomes are. And so that's what I'll spend the first part of the presentation on, which is really focused on, I'll use the example of hip and knee. I'm happy to do the example for anything else if somebody else wants me to go through it at a later date. And I think that I'll show you a place you can go get a reference standard so you can do this for some 50 conditions. And most of the conditions, I believe, represented in the room, somebody has done a decent start at an outcome set for. But we can talk through that first, which is what are these outcomes? And I think it'll clear up some of the questions on kind of what are patient-reported outcomes and patients reporting them versus who reports those things. I think that was an interesting question. Patient-reported outcomes tend to be an objective evaluation of the responses of patients that can then be mapped to some sort of clinical outcome. So if you're taking something like physical functioning in heart failure patients, you'd say, well, we'll ask them about shortness of breath, fatigue, and their ability to do a few activities. And we've actually taken those questions, mapped them against something like heart failure hospitalizations, and shown that if the score on those questions is over 25, you're at greater risk of a hospitalization. So that's the kind of thing you're thinking about when you're thinking of an outcome. It's not just the question, it's actually mapped against some sort of clinical endpoint, but the actual data comes from the patients. Now, who reports that? It actually should be reported by patient advocacy organizations, probably like yourselves, by registries, currently do that a lot, and that's where a lot of this work came out in the US. And then thinking more that each hospital would report those things. And so we can talk a little bit more of that, and I'll try and save some time at the end of my presentation for a lot more questions in this area, because I think it's really exciting to hear you guys think through this stuff and think about how you fit there. So let's really start going through kind of what is an outcome first, and then we'll talk a little bit of what you get out of measuring these outcomes. So I think Scott went through some of this with you guys yesterday, which is that you can measure a lot of things in healthcare. And we really have, and it depends. If you look across countries, it's really varied who decides what to measure. But the most recent ones, which you've probably heard a lot about, is you think about kind of all the different things that you're able to measure, starting up at the very top, which is kind of like initial conditions, or the structure of care, so like is EMR is used or not. Or you can think of the process metrics, how many people were discharged, length of stay, percentage of care done electronically versus not electronically. You can measure experience subjectively, like what was your experience? And then you can measure kind of indicators that are within that, which are more usually clinically oriented. All of these things can be measured and reported on. The only issue with them is they don't tell you about what you actually wanted from the healthcare experience, which is generally the outcome. And so I want just to orient us in that, which is that when we think of outcomes, if you'd say that is length of stay an outcome, not really, because you're not sure if shorter or longer length of stay is right or wrong in every scenario. An outcome is what was achieved for that patient at an individual level. And so let's talk about that, and we'll kind of use one end-to-end case to go through that. If you think of the hierarchy of outcomes, and did Scott show you guys this? Show of hands? No? Okay. So you think about like the hierarchy of outcomes, like what are these things? And can everyone hear me if I kind of walk back here? In the back? Yes. Awesome. I'm pretty loud. So if you kind of look at the hierarchy of outcomes, it's said, and you can probably break this up a million ways, but there's... Oh, am I? Yeah. Apologies for the recording. What I was going to say is if you look at the hierarchy of outcomes, what they say in kind of like three major buckets to look at it is there's three tiers. The first is what it calls really objective measures of what happened to you and your current health status. So this is survival, and this one is actually pretty well measured almost everywhere, and it's kind of your first base level. But below that, the second one is kind of poorly measured currently almost everywhere, which is really your status and degree of health achieved or maintained in a period. And we'll walk through what actually those kind of outcomes look like. Your next tier is kind of things that are more about the process of recovery. How long did it take you to return to normal activities? What are you able to do after your treatment's done? What parts of the treatment process did work or didn't work, and how do we flag those as issues? And then finally, you're thinking more about like sustainability of health. So long-term recovery, any kind of long-term consequences of therapy, rehospitalizations, readmissions could fall into this bucket depending on the condition. And so this is kind of your hierarchy of outcomes. And what I want to do is want to go down into one condition now and show you how these would map, let's say, to an end-to-end standard set for one person. Oh, and I'm failing here. There we are. Brief quote before we jump in, and this is from the organization I used to work with, AI Chum, which has focused a large percent of their time, effort, and money on building sets of outcomes alongside patient groups, physicians, and researchers that can be measured at a disease condition level. And so I'm not sure if you guys received any materials from them, but a lot of your disease or standard sets of outcomes, you can kind of look up for your disease on their website, take a first look and decide, does this make sense, yes, no? And hopefully a lot of them do make sense, because if not, I did a poor job a few years ago. So what they say here is outcomes are the results people care about most when seeking treatment, including functional improvement, the ability to live normally, and productive lives. And so that really should ground you in kind of, these things are based on what was achieved exactly for you. Oh, there we are. So let's kind of deep dive into the hip and knee standard set. And the reason we always choose hip and knee, I think someone asked me, like, why does everyone kind of present hip and knee slides? It is probably one of the easiest ones from a terminology basis and from an understanding basis, because almost everyone can imagine the functional use of like a hip or a knee joint and how changes in that will change one's ability. These same things exist for nearly every condition. And so it's not just the big surgical ones like hip and knee, prostate cancer, et cetera. And so if someone wants to go through kind of another condition with me, please let me know. But in the hip and knee standard set that I just put together, what they did is they create this kind of wheel which says, what are we measuring? What would we want to measure for each individual to know if the care they got met their needs, and that we could compare the care they got between the care other people got to see, was it better or worse, what could have been improved, et cetera. And so I really want to dissect what's in this wheel, because if you look at it from the top, you can see things like mortality and readmissions. That seems pretty reasonable, and you're like, okay, those sound like things I could measure. Then you have something like hip and knee pain. Again, how do you measure pain? Pain sounds subjective. Do I just ask someone, how much pain are you in? They ask for physical functioning, which again sounds kind of nebulous. Physical function can mean many things to many different people. So how do you do that objectively? Going down to work status or health-related quality of life and overall satisfaction. Again, you're thinking of these questions and you're like, these could all be a one-off conversation, and don't we already have those, but how do we objectively measure it? And then finally, you have a number of kind of treatment progression, surgical needs, and reoperation kind of things. So let's actually look at what's behind each one of these and the survey questions there, because I think that'll give you a lot of flavor or understanding of what these patient-reported outcomes are. And they turn out to be dead simple. I think the one mistake we make in value-based healthcare kind of presentations, we leave the outcomes thing as kind of like nebulous, you shall measure the outcomes and everything will be good. And people think they must be complicated, hard, something other than what they are, but they really turn out to just be responses to very simple questions. So we talked about those three tiers of outcomes, kind of the tier one, survivability, health status, then more process of care, and then long-term consequences. And so you can see how these each map to it. And I apologize, the text is smaller than I expected here, but you have kind of your set of, your first one, mortality, which is kind of a tier one outcome. Then the functional things that happen to you, which in this case would be pain, physical functioning, and health-related quality of life. And so now you've got kind of your tier one outcomes. What happened to the person from a survivability perspective, as well as what is their current physical functioning status and symptom status. Your next tier is more around the process of care. So here we're looking more on hip and knee. One of the big things that happens after you've had a treatment is readmissions if it's a surgical treatment. And also, a good way of measuring kind of, are you doing something, is work status, or I'd say functional status. Are you able to go back to work or go back to your daily activities? And so that's kind of your second tier of outcomes that the standard set captures. Finally, your third tier is kind of rated on the left-hand side there, which is much more the process of care, which is reoperations, revisions, need for new surgeries, and kind of treatment progression over time. And so I want to kind of go through the exact questions that would be asked for each one of these things, just so that you can understand that what's one level deeper than this. Because at least when I first started this, I didn't quite get why this was so revolutionary. So this is the one level deeper version of the outcomes that are in that AI Chum hip and knee standard set. And so you can see the first thing, we want to measure hip and knee functional status. And we're going to track it with something called a WHOIS or a KOOS survey. So let's double click and see what's in there. Your next thing is kind of pain. What kind of question would you ask and how do you track that? The next is quality of life, same question. So we're just going to walk through each one of these and see what questions are behind these outcomes. Oh, am I too far? There we go. So let's start with the WHOIS, which is the hip osteopathic, sorry, the acronym escapes me, but it's basically the hip physical functioning assessment questionnaire. And so this is the question that gets asked to a patient. And simply this, the following questions concern your level of function in performing usual daily activities and higher level activities. For each of the following, please indicate the degree of difficulty you've experienced in the last week due to your hip problem. And you'd go ahead and respond. So descending stairs, do you have none, mild, moderate, severe, or extreme pain? Same goes for getting in and out of the bath or the shower. Sitting, running, twisting and pivoting on your loaded leg, which loaded leg, I find the word a little bit awkward, and actually it's, in certain groups, not proven to be that well understood, but it basically means weight bearing. And so this is an example of what we'd call the patient-reported outcome measure. And so this is a question that assesses your physical functioning, and because it's a standardized question that's been mapped to a standard set of outcomes in previous studies, and we're asking the same question to everyone, we can use it as an index point. So the output of this 5-question response is an outcome. And this would be your physical functioning outcome after hip surgery. Does everyone kind of, or does that seem clear to everyone at the outset? Question?
It seems quite clear. Is this the actual chart that was given?
This particular one, I believe it is. I can't be 100% sure, so don't hold me to it. And so this is one of the things with patient-reported outcome measures. And so when you think about value-based healthcare, the idea of measuring kind of patient-reported outcomes and making them the center of what you'd want to report and call quality in healthcare is elegant. What has lagged is actually, what do we measure? And so when you're trying to figure out what to measure, you're looking for these validated questions that can be standardized across a population. And the really only place you can pull them from is the research fields. And so in this case, the hip and knee researchers have come up with a set of questions. This is one of them. But I think you're drawing on the fact that there's many limitations to what researchers have done, because they use it primarily for study purposes. What needs to happen now over time, and what physicians have been kind of screaming for when you use this, is that these are to be adapted to things that are easier to respond to in daily life. So not when a clinical coordinator is standing over you and saying, well, this is how it works, but rather when you're on your own in your living room on your iPad and you have to answer this. And so the adaptive daily life piece. And second is they can get much shorter. Because as you'll notice, we'll go through kind of the full standard set of questions, but this is a bit long. And as a patient, you might not want to spend, oh, am I out of line? Ah, sorry, we're filming too. I do apologize. I'm trying to talk to them too, because I feel like I talk to this side of the room and they get none of it, and so sorry about that. But sorry to the camera guy.
Can I just ask with regards to that question?
Yes.
Are these questions not subject to interpretation? So for instance, what someone may consider to be a mild response, from my perspective, it could be a severe response in my personal experience. So is there not a certain degree of subjective interpretation?
There is definitely a degree of subjective interpretation. Now, the thing is that subjective interpretation on an individual level tends to be as you say, subjective and variable. On a population level, it averages out quite well. And so when you come to these kinds of questions, since they're indexed and tested in the whole population, and so in this case, this was developed for the US, and so it was tested in about 10 or 12 populations within the US, your expected averages are the same. At the patient level, what you're using these questions for is to look at changes. So any objective one-time measure is like, if I say I'm in moderate pain on visit 1, and then I start treatment, and treatment in this case for hip and knee osteoarthritis is I'm going to either have a set of drug regimen, a set of physical therapy, or a surgical option. The question is what changes here? If it doesn't change, we have a problem. Because the idea would be, even though your starting point might be subjective, your change should happen. Does that kind of answer that?
Yeah, it does, thank you.
Okay. And so this is your kind of first thing, so physical functioning, and this is the example of what one of those questions would look like. But as I said, and I really like the fact that we brought this up, there are limitations already to the questions because there hasn't been a lot of patient input on how they're designed because they primarily came from the research field. And this is kind of where I hope you guys get into it a little bit. Next one. So looking at something like a pain score, again, people say, well, how do you objectively kind of quantify pain? When you have hip or knee osteoarthritis, you'll have it in one or both hips and one or both knees, and you're going to be able to kind of objectively rate how much pain I'm experiencing in those. Now, as we said just now, are these subjective to some extent? Yes, but your change from an anchor point is less subjective. And the whole point of many of these treatments is to look at what is the difference from start to finish in, let's say, your pain or functional status or quality of life. And so that's where you can get that differential change and start reporting that by condition area. Quality of life. And so quality of life for this particular condition, they use a survey called the EQ5D, which comes out of Europe, a registry there called Euroqual. And what it measures is it measures first kind of your ability to perform along these 5 domains. And so, sorry, I'm going to turn over this way again just because I can't see that well on this screen. But what it does is it measures your ability on mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And so it asks you objectively on these 5 questions to, again, provide an objective rating. And then after that, also asks you on a scale to rate the general status of your health. Again, these all seem subjective, but what has happened, again, in the research field is they've taken everyone's responses, made them into population averages by patient type, and mapped them against actual events. So now when a doctor's looking at it, they can say, well, that averages out to a clinical score of X in terms of functional, or what's it called, flexion and extension, so ability to rotate their leg. It averages out into this score in terms of probably disease progression. And so that's how I can start to view these things. And so that's where it gets quite elegant and interesting to try and map these back and forth. Finally, they ask you about satisfaction in employment. And so these are the questions that come out of the survey. Now, how do all these questions come up? And are they the right questions, the wrong questions? So the way AI Chum did this, and this is just one standard set from AI Chum, and there's many others from other organizations too. But the way they did it is they brought together groups of first patients and patient advocacy groups. And so I don't know if a Canadian one participated in this particular working group, but largely speaking, there's patient advocacy groups and patients themselves from around the world. And so in each standard set, that's the first group of individuals contributing. The next group was a set of physicians who were specialists in the field, and in this case were hip and knee osteoarthritis surgeons or people who were managing that condition long term. And then finally, it was the researchers who had spent a lot of time designing surveys like this. And they said, okay, what we want you to do is to sit down and based on those tiers of outcomes, figure out what would be the most important things to measure for most people in order to say, is my treatment successful? And that's how they came to these sets of things, which is, well, I want to know if I can perform my daily activities, I want to know how much pain I'm in, and I want to know if I'm able to go back to work and enjoy life like I used to. And that's how they came to that. So it wasn't that it was someone who said, well, this is what I think a patient should want. It's that these were the list of things that all the patients said they wanted. These were all the list of things that doctors said, well, that sounds like it's clinically relevant to this condition. And then the researchers said, okay, well, we can actually classify that using some sort of validated form or survey. What needs to happen more now is to say, okay, now that we've got a general sense of what could be measured at a condition or disease level, how do we customize those patients to be more user-friendly? How do we make them shorter? How do we make them more clinically effective? And that's a lot of what happens to happen next. But this is kind of the baseline of where we're at. So if you know kind of what to measure, yeah, question.
Sorry, you know what, I just wanted to ask. He said he was behind me, but then he moved, so. Thank you. So if you can flip back to that last slide, please, if you don't mind.
Yeah.
So now we're going into the world of qualitative evaluation when you say, how satisfied are you with the results of your treatment? And the reason I ask this is because we've just gone through quantifying satisfaction with one of our support programs. And we did put through the range, but would it not be the ultimate satisfaction question to be, would you be, if you had to go through this process again, would you come back to this doctor and to this hospital?
So kind of
Because
doing,
you know what, I can be satisfied with a service, but not necessarily I'm coming back to you if there's something I wasn't pleased with. So to me, if you're going to go into qualifying results, wouldn't that be a more appropriate patient input question to ask and to evaluate?
so personally, so that's kind of an example of, or a reworded version of net promoter score, which is basically would I refer somebody else to do the exact same thing? And that is shown in almost all consumer literature to be the best way of kind of quantifying an experience. And so I would agree with you. This particular working group that came up with this, that group of patients, physicians, and researchers thought this was a better way to go. Satisfaction in general, you'll notice it wasn't on that list of outcomes hierarchy. And even when on the wheel, I didn't label it as one of the outcomes because satisfaction is a little bit different in the fact that it actually has a lot of inputs that are not related necessarily to your direct medical care, but are quite important still. And so that's one of the fields I think is actually most poorly defined as far as measurement and use in medical care. And even in this survey, I think you're seeing a reflection of that. So that's where I would land on that. Yes, Net Promoter Score would probably be better in this case. I would disagree with the working group on this one. You would have to decide at a condition level what we want to measure as a country and as a province, depending on how this kind of thing is rolled out. But in general, satisfaction, because it's different than the rest of the outcomes, it's often not quantified the exact same way. And many consumer type applications do a better job at measuring satisfaction, frankly, than medically validated questions.
And the only reason I ask that is if you are basing this system on patient-driven input, how can you not ask that question? From my perspective, anyway. So
Satisfaction has driven us in some weird directions. I'll give you an example, and I won't name the hospitals particularly because it's unfair to shame them individually. And actually, I'll choose an Australian example because it's far enough away that probably none of us will be affected by it. So in order to get satisfaction up, they said, okay, how do we do it? And they kind of had two different arms to a small study. One is they improved their medical care immensely for patients who were doing spine care or spine surgeries. And so they said, okay, how do we get the most cutting edge research in? How do we get trials in? How do we try and improve our outcomes longitudinally over a year, 2 year, 3 year period? And they actually did a really interesting job. They put a lot of money into it, but they were able to actually amp up their outcomes a fair bit. The other sister hospital of theirs, and it's a network of about 50 hospitals that did this, went off and just said, okay, how do we improve satisfaction? And what they realized is that the key inputs that actually changed the scores the most were they changed the cafeteria food and made it much, much better, and they changed the parking price. And those two things, though very relevant, were the primary drivers of satisfaction, and their scores improved far better than the guys who improved their medical care and actually had better outcomes. And so the issue with satisfaction as an outcome is that it can have many more directions or many more causes than those that are directly related to your medical care. Is it an important thing to measure? 100%. Is it the thing to put on top of the value equation? I actually don't know that one because we don't quite know, or I don't quite know, I should say, how to incorporate it into things that are directly related to your medical care versus things that should be part of a great experience overall. But that's how I would kind of view satisfaction. I think a lot of work has to be done there. And what I'm hopeful of is that outcomes can be kind of well quantified and have to be done in a more scientific and rigorous process so you can compare between people. Satisfaction is something that we've learned how to do very well in many other fields. You look at Yelp for restaurants or any other review site you can think of. Consumerism and measuring satisfaction is something that we should be able to do more in a consumer type way than a scientific type way. And that's probably, I think that's happening already, especially if you think of Rate My Doc or any of the more popular ones in the US, WellDoc, et cetera. Those are all starting to, and I'll admit that My first 2 medical appointments that I went to when I moved to San Francisco a year ago, how did I find my doctor? On Yelp. I looked at the last 50 reviews, I looked at the star ratings. Is it objective on the outcomes? No. But from a satisfaction perspective, yes. So I'd like to have the satisfaction piece on one side and the outcomes on the other, and both are important. The one probably is more important to the value equation and driving financial decisions is the outcomes, because it's really related to the medical therapy and how well someone delivers medical care. But whether feet walk in the door will be based on satisfaction. Do you have a mic up front?
Hi.
Question back here.
Sorry. I think this is a good question, but
I'm sure it is.
the other one is process. I think that's what we're talking about. Is there's the outcome. Yes, I have a new hip. I'm fine with it. It wasn't a great experience because I was in emergency in the hallway for 36 hours, and somebody pulled out the catheter, and as they were walking by, and so yeah, I'm very dissatisfied with the process. So those are reflective not of the outcome of the surgery, but of the experience in that particular institution.
Totally agree. Yeah, I would call that the outcome of the process in this case, but yeah.
So I liked your example about the parking and the food, and I would, I think that those could be relevant. Let's talk about the parking. That could be relevant if somebody says, I'm not going to my doctor's appointment today at that hospital because I don't
expensive.
have any money to park. Or I don't have, like some of these could actually be social determinants that impact an ability to get to even if you like the facility and the medical care is great and you want to go, some of them I think will fall in that bucket. Some of them, like the food, well, I probably don't think, whether it's good or it's bad or it's indifferent. It's always indifferent.
I think they should have good food. I'm just not sure that's the outcome we measure.
That's what I'm saying. That some of those things that you mentioned could really affect your medical outcome. Some, just make you happier to be there and not so happy to be there. So even within that, I think that's where I think that it's one of the many, many places I think that having patients looking at these things will give you a better understanding of how they actually do impact medical outcomes.
Totally agree. So, one more question, sorry.
Sorry. Just want to know, does iChum track the value of complementary care, especially when a patient exits the conventional care track and flips over to complementary?
So it depends, you have to do that by condition. So for each condition, so I think for hip and knee, the treatment types, I should have it on a slide coming up, but I believe that it's basically medical treatment, physical therapy, which isn't really, I wouldn't call that complementary care. It's probably not complementary care as you're defining it. Or would that fall in? No.
Complementary care is so wide.
Exactly. Okay. So I would say that what generally is done is that you look at what are the different treatment options for a given condition. In hip and knee osteoarthritis, it's kind of surgical, drug-related, physical therapy, and diet and lifestyle modification related. And those are all valid. And what you'd say is those are 3 different kind of treatment approaches, sometimes used in conjunction, sometimes used individually, but you want to track the outcomes from each, for each type of patient, for each stage of the disease. And what that basically tells you is, and we'll get to this later, but when you're trying to map out as a patient, when you walk in, you say, okay, well, you say my disease is here. If I follow the surgical route, where will I end up in 6 months, 1 year, 5 years? If I follow the drug route, where will I end up in 6 months, 1 year, 5 years? Same thing if I do diet and lifestyle modification. And now I know. And I would have a good sense of what other patients like me's pain looked like in those time periods, their functional status looks like in those time periods, and their quality of life. And now it's on you to make a decision. If you want less pain up front because you don't like the idea of a surgery, and you're okay with having a little more long term, that's your decision. And that should be fine. But that's how it's thought of. Now, complementary, I think, medicine is very large, but I would say that wherever there's a valid treatment option related to a disease condition, it should be included as one of the treatment options that's tracked against the outcomes.
But who makes that decision?
That would be the group kind of coming from the standard set. So if that's you guys doing it, I would argue you. So you kind of say then first what to measure. The next question is when to measure it, because you actually have to measure these at the same time points for everybody, so you know that the outcomes comparisons you're doing occur at the same time points lined up with one another, so that at least from a time perspective, you're removing some variation. So for the hip and knee standard set, at least, what they said is that we'll kind of do it at baseline. So this is diagnosis of hip and knee osteoarthritis. And either just after a change in treatment, and this could be surgical or non-surgical, so just before and just after those points, or at a yearly level. Because what they said is that usually these kinds of things tend to change in patients at a 1-year level and not much faster. And so if we're tracking rate of change, this is the right cadence to do it. And people say, for how long do you track this? You track this forever. This is not something that you kind of stop. You do every year, you would do the same survey, and you'd be able to figure out kind of what is the progression over time, and is my treatment approach working or not working? Hip and knee tends to be one of those things that takes at least 6 months to take effect, and so that's why the timelines are at the year level. Other ones are much shorter. But the second thing you have to align on is how often to measure, and kind of in what instances to measure. And in this case, this is what was decided there by that working group. Then, I won't go through all of these just from a time perspective, and we want to watch a short video after on the more fun stuff of like, if you measure this, what happens? But in general, measuring the outcomes and then doing it at the right time isn't quite enough, because you actually want to be able to say, who is this data applicable to, and how do I cut and dice this population? And so this is just an example of some of the Casemix variables you'd measure, whether it's date of birth, which really gives you age, treatment type, other lifestyle, living condition, or some of the, I think, what you call more socioeconomic factors, comorbidities. You'd want to capture all of this, and the reason you want to capture all of this is so that when you're actually doing outcomes comparisons, you're comparing like-for-like patient groups. And so somebody who goes in for a hip or knee surgery or hip or knee osteoarthritis that has diabetes and heart failure is going to have a very different treatment plan and, frankly, different outcomes from a functional status than somebody who does not. So you need to be able to subcategorize that, and that's the general concept here. Now, this standard set that I presented, this is just one of, I think, that's 50 that are available on iChum's website now. Go there, take a look at the one that is the disease that you know best and matters most to you, and start to understand whether this kind of process makes sense. You can also read about who was in the working group, so you'll see which patients, which doctors, kind of which research people were there, part of each one. I would say the one thing that has happened, and they, at least at iChum, raised quite a bit of money to try and get more patient groups organized and part of it, and that's one thing they struggle to get involvement in all the time. And so it always has to be an international coalition, can't oversample from North America. North America, we tend to have slightly more active patient groups than East Asia or some parts of Eastern Europe and things like that. But getting that group together was difficult. So I think in some of these sets, not enough patient input could have gone into it, and more could happen. And that's part of, I think, what hopefully you can do if you're taking these and taking it one step further, which is, well, if there's a baseline, what do we want to add to it that makes this our own as Canadian patients? And then how do we do this nationally? So that's kind of a standard set. That's what goes into it. And that's what you can think of. If you're measuring the outcomes related to one disease condition, that's maybe a snapshot of what you'd want to look at. This will be different for every condition, but it generally measures those things that patients have said matter most to them and what they want to achieve through the course of that treatment. And so I'm hoping that for many of you that was probably review, but for those who hadn't seen that yet, that should demystify this word outcomes. Because again, it kind of gets thrown around a fair bit, and we never really know what actually is behind it. So then let's do 5 minutes, and this is a quick 5-minute video on what you can do if you get this data and you're measuring this data, right? I'll then review some questions that came up yesterday, just quickly going through some slides, because some people asked some good questions on what happens when you show outcomes data. Can you show me an example? Or show me an example that's a little more about what these curves look like after you measure this on 500-600 patients, and you can see kind of the responses, and what does it tell us? And then hopefully we can go to questions. Oh, do we have volume? Okay.
Currently, we see dysfunction in healthcare systems around the world, despite an exponentially growing knowledge base in medicine. Estimates indicate that 30% of healthcare spent is wasted. There's wide variation in both health outcomes achieved and costs across providers, regions, and countries. And costs are rising at an unsustainable rate, outpacing GDP despite pressure by governments and payers to control cost. We need a healthcare system where patients and stakeholders are aligned on the definition of success. That is, delivering outcomes that matter to patients at the lowest cost. This is value. Sylvie and Kabir are two retired adults about to start their journey through the healthcare system. Sylvie lives in the world we know today, while Kabir lives in the world of the future, with a true value-based healthcare system. Kabir and Sylvie have been experiencing long-term hip pain. Hip replacement surgery is being considered. Sylvie is referred to a hospital near her home with favorable patient experience reports. Unfortunately, it has high readmission rates and performs a limited number of hip replacements per year. Readmission rate is the only quality metric that is measured by the surgical unit, and this data is not available to the public. In contrast, Kabir and his primary care physician consult a website that compares hip replacement outcomes across all hospitals in the country. A hospital located an hour away is highly ranked with low readmission rates and scores highly in patient-reported mobility post-surgery. Unfortunately, Sylvie cannot remember her full list of medications during the preoperative assessment. This forces the surgeon to initiate an administrative procedure requiring her doctors to complete several forms. Scheduling Sylvie's surgery is delayed by a week. Kabir's surgeon asks for his consent to access his electronic medical record. The hospital system is linked with others in the region, allowing him to quickly gather all of Kabir's medical history from previous visits. Sylvie's surgeon selects a prosthesis that he's been working with in recent years and with which he's the most comfortable operating. For Kabir, on the other hand, a multidisciplinary clinical team with a surgeon, a geriatrician, and a physiotherapist discusses his mobility goals. Using Hip4Me, a decision support tool, and noting that Kabir is a devoted cyclist, they agree on the best prosthesis. Kabir's doctor books the surgery with a colleague who has outstanding mobility outcomes with the chosen device. Sylvie's and Kabir's post-operative journeys are complicated when they contract an infection at the surgical site. Both must undergo additional surgery to replace the prosthesis. Sylvie's hospital operates under a fee-for-service reimbursement plan. Sylvie is required to pay a $4,000 copay, while her insurance pays an additional $6,000. Kabir's surgery was charged as a bundled payment that included the cost of all interventions associated with his hip replacement, beginning with his preoperative appointment and including the second operation. At Kabir's hospital, the financial incentive to reduce post-operative infections is strong, and his infection is a rare exception. Sylvie's medical staff assumes Sylvie's rehabilitation spot will remain available even after the delay from the second surgery. Unfortunately, the bed is given to another patient. Sylvie is sent home after one extra day in the ward. However, she faints soon after coming home and returns to the hospital emergency room. Sylvie's stay is extended to 5 days before she feels comfortable to return home. In Kabir's case, the rehabilitation center was immediately alerted to ensure a spot is kept available. His medical team understands the importance of early rehabilitation. A delay has high chances of impairing the surgical outcomes for which the surgeon is responsible. Kabir's bundled payment includes the rehabilitation cost and is linked to patient outcomes, incentivizing the surgical department to collaborate closely with rehabilitation centers. Kabir's rehabilitation is successful, and he's able to begin cycling just 6 weeks post-surgery. Sylvie's experience is not the product of bad intentions, but the result of rational responses to the complex rules and incentives that have evolved over decades, leading to negative unintended consequences. A focus on value can transform Sylvie's story into Kabir's. To do so, we need a truly patient-centric healthcare system that starts with measuring health outcomes and combines informatics with key enablers and a supportive public policy environment. In the end, we would create an evolutionary healthcare system where outcomes transparency allows us to learn from systems around the world, identifying best practices and eliminating wasteful spending that does not drive value. This is the future of healthcare. This is value-based healthcare.
So I was trying to think of a full presentation to kind of convey those concepts and had like 30 slides and then realized that some colleagues of mine previously had done this in a 5-minute video. The link for that is available. It's on YouTube. if you want to use it in your own. But hopefully that starts to link the different concepts of how, by starting measuring outcomes at an individual level, that becomes the data set that allows you to measure the same thing between people, and actually really helps things like interoperability between EHRs. Because if you have the same data sets and the same labels, suddenly transferring information isn't as hard. It allows you to link payments to something objective across a care, what's it called, episode, and have that, a whole team work on that for something like a bundled payment, because everyone's working towards those same goals. And allows you to then start to make choices. And so that, I think, is where I'll stop and pause and take some questions. I have some more slides to go through if we have time, and if we run out of questions, or everyone's turned off by me, and then I'll just talk till the end. But in general, that's kind of what I wanted to convey today. First is, this is what an outcome actually is, but it's not that complicated. It is pretty straightforward, and it's what you'd expect. It's what you usually want and ask for when you're in a doctor's office about what's going to happen to you next. It's just codified in a certain set of questions, and those questions can be redone or rethought through as groups think of them, as long as it's done in a validated way. And the next is, what happens if you start to measure that fundamental information unit? And the application of the information, although it's not kind of guaranteed that all those things will happen immediately, they all can happen if you have that information starting to be measured. And so then it's about pushing everyone to do the right thing. And so, thank you.
Thank you, Andre. That was a great presentation, really helpful. Leah and I, we were analyzing 6 of the medical condition standard sets on the iChum website. And when we were doing that, we noticed there were lots of references to a variety of surveys. And you showed us some of the details of those. Are those surveys accessible anywhere? Because we couldn't find them.
So if you go into the standard set where they reference the surveys on that timeline, it'll say, click here in the stupidly smallest text you can find.
Oh, we didn't see those.
Click here. Or you can just Google the survey name. They should come up as a PDF. The majority of surveys, so again, this is kind of everyone's up to their own way of creating kind of outcome standard sets. iChum tried to only choose surveys that were publicly available and free for use by hospitals and care providers. And so the majority, I'd say like, I don't know the exact number, but let's say greater than 80%, are all freely available. All of them are available to view. A small subset, I think the one example I can think of is for heart failure, something called the KCCQ that measures fatigue, shortness of breath, and functional status. That one, care providers have to pay to use, but almost everything else is freely available, and just click on it and you get it.
Awesome, thank you.
Yeah, and the surveys themselves were developed by kind of individual physicians and researchers in each different field. It was just put together by this group, or these groups, I should say. Oh, your mic's off, I think.
Press the mic button. That's better. Great. I apologize if this has been said, and I apologize if this is tangential, but listening to all these conversations about outcomes-based care, one of the things that keeps constantly reverberating in my brain is how we talk about health and healthcare. And I think, and this is going to sound maybe philosophical, but when we use words like patients and providers, we start to frame a discourse that is by its very nature hierarchical, highly structural, and we start to foster this disassociation between people and their health experience. I think that's a fundamental problem that permeates all of these conversations. The second someone walks into a health environment and you describe them as a patient, you're creating a dynamic that's probably pretty dissociative for that individual. It's the same way like we talk about organic food. Well, organic food is just food. It's not something new, it's just food in its normal form. We're just used to getting food from a can or a box. That's not food. Organic food is food. I wonder what we can do collectively as organizations, as people, as companies, as to start reshaping a narrative where people feel a sense of deeper connection to their health as an experience, not as a commodity, not as something that's acquired or prescribed or directed, but something that's lived with moment by moment, day to day. I don't think anything that we do without correcting that notion first will be particularly effective because I think you'll always have this awkward dynamic between a person's sense of self and their ideas about health and their health experience. Again, I know that sounds lofty and abstract, but I think the way that we think about or understand our health is like the first mover in all of this.
I would say that, so one thing to be kind of, I guess, value-based healthcare hat on and off. So value-based healthcare hat on. I will say there are many things measuring outcomes will help solve. The disparity in the power relation, or the disparity in the hierarchy of the relationship we described, gets partially solved by having more knowledge of what you could achieve, but not fully solved because, as you said, the labels themselves cause a kind of fundamental issue. Measuring outcomes won't change that. On the value-based healthcare hat off, on the need to reshape the conversation so that we talk more about people living with heart failure rather than people who are patients with heart failure or heart failure patients. Couldn't agree more. I would say that I'm guilty of this probably extensively yesterday and today in how I describe things. And that's more of a general training thing. I will say that if you have kind of, from an objectives perspective, that last statement you said, which is that if we don't fix that first, we won't be able to get very far elsewhere. That's the one I would say, don't say we have to fix that first and stop doing everything else. Try and do both, or there's more than two levers you're gonna have to pull here, but try and do more than those two at the same time. You're probably gonna wanna work on this because it improves things like our ability to have a reasonable payment system, our ability to know whether the outcomes that are achieved at a disease condition level actually make sense, and whether I should subscribe to a given treatment type. And there's a whole set of reasons to do that. On the other side, there's a whole set of reasons probably to have the conversation on how to improve the disparity in power there, and do that at the same time. But I would say do them or at the same time, rather than think of them as one needs the other. I don't disagree with you that some things won't be solved in either area unless both happen, but I would argue that you have time and we kind of need to do all.
Yeah, I wasn't suggesting that it's sequential, but more so that it has to underpin how we think about just health in general. The same way, 100 years ago, we used to think that the only way to moderate your sense of being a spiritual being was that you had to talk to a priest, that you could have no relationship to something, how you conceived that was bigger than you unless you were talking through this intermediary. I think we still have these notions around health. And I think a lot of people, and if you look at things like non-adherence rates and people just not moving through their experience of health, a lot of it has to do fundamentally with that sense of disassociation.
Gotcha.
Can I just comment on that as well? I think, you know what, I would disagree in the sense that this whole principle depends upon patient input. But you need buy-ins from the decision makers or in this case, the government, to take that input into consideration. So my wife's a director at our local hospital, and orthopedics is part of her portfolio. And one of the major drivers in their process decision-making is, you know what? Bottom line, how much money is the government giving them? We're gonna give you X amount of dollars for X amount of hips and knees. Mm-hmm. And that's it, basically. How they respond depends upon where they are towards that funding target. And when the government makes these funding decisions, unfortunately, you know what, they have criteria that they have in mind that is important to them in their decision making. So I'll give you another example. In Scarborough, there are 3 major hospitals. When they separated into the different LHIN, the one and you may not know Scarborough, but it's in northeast.
I know Scarborough well enough, but no, not the hospital.
It's in the East End.
Yeah.
But rather than having them be treated with the other 2 hospitals, they're lumped in with the other 2. They said, oh, you know what? There's too much population in Scarborough. Let's associate them with the Central East LHIN out in Oshawa, which is miles away. Mm-hmm. So from a numbers perspective, yeah, that works great. It's equitable. From a reality perspective, are you kidding me? You're expecting people in Scarborough to go to Oshawa to get treatment for oncology when they don't have a car? There's no public transportation directly from Scarborough to Oshawa? It's like, give your head a shake. And this is the whole problem for me, is when you talk about, yeah, ideally, patient input and quality of life, quality of care is very, very important. But until, as we've all said, you get buy-in from everybody in the process, especially the decision makers. You just, you know what, you're just talking to hear yourself talk. And you can measure all these parameters, but until your funders buy into this process, it's a moot point. And you know what, I know, I'm probably
No, actually,
not.
no. I think this is actually a really valid question with hopefully a decent response. You might have a response to my response to some extent. So don't let the mic go too far. But in general, the thing that she laid out there was that the hospital is measuring itself in one way. And it's measuring itself really, how many hips and knee surgeries can we do with the budget we've got? And clinicians and hospitals honestly do their best. I've worked in that side of the game a number of times, and they try very hard to do the right thing from a patient perspective, despite the fact that all the things they're measured on and held to are usually not related to the patient. But so they have that set of things. Again, the government has a different set of things. How do we distribute money across the population, make it more equitable, think of redistributing things? I don't know the Lynn example well in Scarborough. Grew up in Mississauga, so understand the area at least, but wasn't around for the Lynns. I'd left already by then. But in general, they're measuring a different set of things. What the idea here is that this isn't patient input. So this isn't that, well, we want to know about patients' quality of life so we can have their I guess, perspective on this condition. This is the data upon which you would say, are we succeeding in our care for a given medical condition or not? And who is succeeding more than others and who is succeeding less than others? And by creating a data set that we call the truth on are we succeeding, and then being able to compare that between different care settings, it creates one source of truth for everyone to draw from. And that's the concept of outcomes measurement. It's not the fact that everyone measures their own outcomes on their own. There's use for that, but that's not the ideal scenario. The idea is everyone's measuring the same thing at the same time points, and that's the ground source of truth for decision making. And so suddenly that becomes, you're able to have alignment between these parties based on a common set of facts, which currently doesn't exist. Now the question is anyone interested in hearing these facts? The government of Canada signed with the rest of the OECD countries, signed an agreement, would have been now in 2016, saying that they fundamentally believe that value-based healthcare is the way they want to go. And the minister then signed up and said, okay, we're going to start a bunch of things in pilots. And I think you'll hear from Greg from CIHI later. He'll probably talk a little bit more on the government perspective, because again, I'm not in the government, so wouldn't be able to speak on that behalf. But they've been looking at this very strongly, but they're thinking, how do we make it happen? How do we actually get doctors to measure these things? How do we actually collect that data and aggregate it? So they're dealing with those questions, but the interest is there. Physicians have been screaming for a very, very long time, allow us to know what happens to patients and allow us to manage people more longitudinally rather than just being paid for exactly what we've done, because that changes fundamentally how we can manage people. If we don't get paid for things, we don't have office staff, resources, and time to do it. And so though we'd love to, it just doesn't happen. And unless you want us to go into financial, or ill benefits in order to do this, and many do. And that's many of the, you see these kind of stories about the care system, and I always take them with this mixed positive benefit where it's like someone has gone out of their way and against all the incentives set up for them to do something great. And you're like, that's a fantastic story, but a terrible system failure. And so it's kind of one or the other. But they've been wanting to do this. So I think that there's a perspective here that a lot of people have wanted this for a long time, but it was a hard thing to codify and define. Now that that's there and everyone is starting to be interested, you probably have to start it from all ends to make it happen. Some countries have started top down. Norway, the Netherlands is an example. The health minister came out and said, hey, we're doing value-based healthcare. We're changing reimbursement to bundled payments, and we're going to start measuring outcomes in this way. And they've made the most progress of any country in the world. So yes, that's one way of doing it, kind of government top down. Other hospitals, especially, and this is largely I can think of US and European examples, have gone where we just think this is the way we're going to give care in the future. And in the US, consumerism is a very big deal because you get to shop around quite a bit within your healthcare network. And so they'll say, well, this is how we're going to get boots in the door. We want to differentiate ourselves by saying we're the best at these kinds of outcomes that we can simply and easily explain to everyone at the table. And so they've gone it that way. I think everyone has to kind of go at it in different angles. Patient advocacy groups, just as much as everyone else, probably have to say, well, this is how we want it to happen, and this is how we can start to generate this data. Because if you do, others will use it. And that's a good question to ask Greg as to how they would use it if you start to generate these data at a disease condition level for different advocacy groups. But that may even be my overly optimistic view on how to get this started, but I'd say everyone somewhat wants it, and it's needed that everyone kind of decides that we're going to do something rather than say, well, wait for the government to change their mind, because they might not for a very long time. And you probably can get there faster if we all try something and one of the things sticks. Time?
So we have a couple more questions. How's our time?
We're into our break at this point, so we just need to decide that. Perhaps, are you going to be here for a little while today? At least let's let this question. Okay.
Thanks, Louise. Michelle Mujumdar from CATA. Thanks very much. I'm sorry I missed yesterday. Looks like it was an interesting discussion just from the recap of the slides. I'll try to make this short. I'm very familiar with the work of iChum, as well as others that are into creating outcome sets, whether they be standardized or harmonized. So I guess I'm just wondering two questions. So one, is there any collaboration in this space? So for example, between the work of iChum, Comet, other ones that have used more multi-stakeholder approaches to create these outcome sets that include the patient perspective and are actually including outcomes that matter to patients? And second question, do you believe that there's appropriate uptake? I guess I'm shifting the use of these more upstream. Do you believe that there's appropriate uptake of the good work that's been done creating these outcome sets by technology developers?
By technology developers. So first question on, is there enough collaboration between the groups creating these outcomes? Yes and no. I think Comet's one that iChum has very strong relationships with. If you look at the IHI and all of their sets on triple aim and things like that, Donald Borwick is kind of the starter of that and also on the board of iChum. And so there's a fair bit of collaboration there. They have different things that they think are important to measure. So there's some fundamental differences there. But I would say that they're probably not doing enough to harmonize it all for the world. But that's because they're each individual organizations trying to push for changes to happen that they think will kind of get things there fastest. And it's probably a combination of what all of them are saying that has to be done. So iChum's is basically value-based healthcare. Value-based healthcare on its own doesn't solve the problem he kind of raised, which is about disparity in power between, let's say, patient and doctor. So there's multiple things that kind of have to happen there. And that's how I view that. Not enough collaboration currently, but probably needs to be more than one idea out there anyway, and we have to follow more than one. On the view of technology companies taking this up, in general, the actual measurement of these kinds of outcomes, these surveys are easy. They're kind of like SurveyMonkey-style surveys. What's hard is to do it at the right point, so in the clinical setting, integrate that with clinical data. So into EMRs can be really tricky, especially depending on what kind of systems you've adopted, and then have it available to the doctor to use in a visit such that it's not just something recorded for the sake of retrospective analysis, but it's used prospectively in the care decisions. And that's the part that's really lagged, and largest reason it's lagged, I think, in almost all the countries that we look at, is because for the financial benefits of measuring these don't exist, so the most people who do it largely altruistically. And whole hospital systems like Providence St. Joseph, which is like 139 hospitals, is about the size of Ontario, if you think of its size, they're doing it individually because they think it's important. But the reason, let's say, all the other hospitals around them aren't doing it is because there's no actual funding for it yet. That's coming in some cases in the US. A lot of the bundled payments require outcomes measurement, and actually this hip and knee standard set was the one they referenced, and they took about, I think, 3/4 of it and put that into the total joint replacement bundle that they put in the US, and that's what was measured in that joint replacement bundle. But the reason I think that technology companies aren't doing it is because hospitals can't demand or pay for it because the reimbursement piece isn't there. My take.
So I know there's one more question. Go ahead, and then we'll move to break.
Yes, thank you. Dave McMullen from Myeloma Canada. Andre, you mentioned Netherlands and Norway as examples of countries that are more...
Norway in error. Netherlands and Sweden should be the ones we think about. Sorry.
Okay. They're more advanced in outcomes measurement and value-based systems. From your experience, are there any models that you think might be appropriate for Canada or models that we could learn from? Any particular countries in Europe or elsewhere?
I think the simplest one is something like the Netherlands. It's very similar from a system perspective, or has many similarities, I should say. Not all, but very similar from a system perspective. And their approach in order to attack this, from kind of getting the government to take the initial stand, and then payers and both kind of actually physicians coming together and saying this is how we'll actually do this and track it, has been really successful. And it's largely because they had almost all parties kind of raise their hands and go. And they got lucky with a few examples where you had some pretty revolutionary individuals. There's a guy who started a company called Diabuter that was bought by Medtronic. It's a good case to just read and watch a few videos on. But he himself, I think he mortgaged his house and started this off and kind of took a chance and went into debt for a very long time. But that was one of the best case examples that everyone then drew on in the Netherlands to kind of build up this. I would say that as a country to emulate on the outcomes measurement and value-based healthcare front, that would be if I had to pick one example of how to do it. If you're looking at information systems and how you can have like a single information system that has everyone's information linked across settings and linked back to all different types of data, Sweden's probably a great example of that. They've had fantastic disease registries since the 70s. That's kind of where a lot of the concepts of value-based healthcare came from, because they had that data to start doing these kinds of analyses. And they've, from a data system perspective, have structured that very, very well, and have structured the discipline of measuring these things very, very well.
Thanks, everyone. Andre, are you here a little longer?
A little longer. I have to jump on a flight to Chicago about an hour or two, but I'll stay for the first 30 minutes, and any questions, I'll
So
take them
if
back.
people have questions, try to grab Andre during the break, and we'll see you in what, 10?
10.
Thanks, everybody, in 10 minutes.
Thank you so much.